we have made our company more about care management. We focus on that with our families. With that, we do in-home care, and our services cover everything from companionship, homemaker, to specialized care, dementia, Alzheimer's. We do a lot of personal care, working with long-term care insurance folks, or actually personal care with everybody. But we do that bath visit and helping with the activities of daily living, anything that's hands-on, transferring, ambulation, and then partnering up with great companies like David's, anyone that does the medical side. We have a strong relationship with those companies in Colorado. So often clients and seniors and other folks needing services may be working with us and another agency. We specialize also, or we love helping the care management part. I'm finding more and more of our families, they're busy, they're working, they're in Virginia, across the country. So we're trying to work with families also to connect them with community services, not always us, but we're going to work with our partners to just take the stress out of the family situation and give the best care we can to our clients. So that's kind of a broad view of Home Helpers here in Metro Denver.
Home Helpers itself is that a national organization?
Yeah, that's a great question, Bob. We're part of the Home Helpers Corporation out of Ohio. We're in all 50 states. I think we have about 302 offices. Some of the metro areas might have 5 or 6 different owners. I'm really lucky because I've got Denver, Colorado proper, including some of our close suburbs, Littleton, Lakewood, Arvada, down to Castle Rock. But we also have other offices throughout the Front Range area, and we actually have an office over in Grand Junction, Colorado. Not my owner. I don't own that office. We have a wonderful lady over there.
Okay, thank you. So, David, could you speak a little bit more about GoldLeaf, please? And also explain your alter ego picture.
My name is David Geras, and my company is GoldLeaf Home Health. We provide the full continuum of care, both non-medical and medical in-home healthcare services. We provide a lot of the services that Rick's company provides on the non-medical side, companion personal care, but most of our patient census is compromised or made up of medical home health cases, and we are ACHC accredited and CMS certified for Medicare and Medicaid. We also accept United, Anthem, Cigna, and Kaiser. We have a Kaiser contract, one of the few agencies here in town that has a Kaiser contract. So we can accept most major insurances. And a lot of people ask if non-medical companion and personal care is covered by health insurance, and it is not. Unfortunately, most of those costs are paid out of pocket or covered by long-term care insurance. Some Medicare Advantage plans are covering home health aides and companion care in some other states, but most of the payers, insurance companies have not rolled that out here in Colorado yet, unfortunately. But I think that should come next year, so stay tuned. We're locally owned and operated, based here in Denver. Only operate in Denver County and the surrounding 8 counties, Denver and Boulder. One of the reasons why I got into the business is because of my family history of Alzheimer's disease. So I'm very active with the research, Alzheimer's research here at the University of Colorado Answers Medical Center and at DU, Noble Institute for Healthy Aging. A little picture on my profile is Ryan, the companion bot, a very advanced artificial intelligence companion bot development initiative underway at DU, University of Denver, Noble Institute for Healthy Aging. Because of the massive shortage of manpower to care for our aging population currently, it's only going to get worse as time goes on, especially here in Colorado. Ryan, the companion bot program, and others like it are paradigm shifters in our industry, and they're going to fill the void of the lack of manpower to help care for the aging population. He's provides peer companionship right now, but it's a fascinating research initiative. I can explain more about it later if you like. But that's GoldLeaf and myself in a nutshell.
My name is Damian Rosenberg. I'm with Pasco Personal Assistance Services of Colorado. We are a Medicaid, pretty much primarily 99.9% Medicaid agency that was established in 1992. So we're coming up on our 30-year anniversary, which will be a hoot, as they say. We are Class A, Class B, meaning we're skilled and non-skilled. And we do a lot of programs with both. We are probably most well known. The founders, actually, my founder is my father, who started this company. He was a big civil rights advocate for people with disabilities in the 70s, and he was a co-founder of a place called Atlantis Community in Denver, which was the third independent living center in the country, getting people out of nursing homes into the community. So going back to the early 70s, so kind of been around people with disabilities my whole life with him, and then in '92 he started Pasco, and he had some success because of where he'd been from. And in '92, really the home health arena wasn't as jam-packed with providers. It was really VNA, Visiting Nurse Association. Pasco was one of the early ones, and the landscape looked a lot different. There wasn't on-call. There wasn't people that if you were stuck in your chair, you might have been stuck in your chair all night. People that would lead like banker's hours. You'd go to sleep at 9 or 6 in the afternoon and wake up at 10 in the morning, and people don't really live like that. So I think we kind of created something where just being more cognizant of the people that we're serving, and kind of coming from that civil rights background, really getting away from the medical institutional model, never calling our clients patients because they were getting out of skilled nursing SNFs, skilled nursing facilities. And it was very important to them to maintain that dignity, that level of dignity. The big watershed moment for Pasco was in '99. A mom said, you're sending in staff to our home. Why can't I just do this? So we were just really the right place, right time, had a good, we're really close with healthcare policy and finance, worked a lot with them. And then with CMS, Medicare, Medicaid, and we asked the question, is it possible for a family member to do this work and get paid? And they said, yes, as long as they become a CNA. So we offer a lot. I think a lot of people think of Pasco and it's more for kids, but we do lifespan. So again, all Medicaid and a lot of different service delivery arms. So I can get more in the weeds in a bit, but that's sort of the basic thing. We have about 1,500 clients that we see daily. About half of those are under 18, and they are aging. So we are one of the larger Medicaid, if not the largest in the state. And the people that we employ are full employees. They're not contractors, so 28 hours is full-time equivalent. We do insurance, there's PTO, life insurance, and a lot of other benefits. So we feel very good in that space as being a good employer as well.
So A and B, medical versus non-medical or personal care, prices are going to be pretty wide there. But I just did a survey. I actually brought someone in from an outsource, and they worked on Denver Metro. And what we came up with on private pay, you're going to hear right now, depending from North Denver to South, whether you're rural or up in the mountains, but $32 to $36 an hour. Many of the companies now are doing a 4 or 5 hour minimum. And then when you get into specialized care, which would be like dementia, Alzheimer's, you might see the price come up a couple bucks an hour. I saw on the survey 38 an hour, and often these are 4 or 5 hour type minimum shift, private pay clients. And then companies that go all the way up to live-in care, which includes us. What we got in the survey there is very expensive. So you might see anything from $450 up to $700 a day. So for a family, You know, I remember I'm old enough now that I'm going to become a client here in a few years, but I can remember in the early or the late 90s when I was living in Albuquerque, and live-in care at that point was like maybe $200 a day for a family. And so you can see in 20 something years here, it's almost tripled, quadrupled. So we're all trying to figure that out. But I think on the private side, those are the prices you're going to hear here in Denver. Living care for our company means we might have a team, 3 different folks that are doing 2, 3, 2, and then you set that schedule. So you have kind of a 3 different people that are working with the family during the week. It's not where they live there permanently. So that's what's considered living care with agencies.
David, could you talk about the difference between, you mentioned earlier skilled and unskilled, A and B. So what is the difference really?
Well, the biggest difference is skilled is all the medical care, so skilled nursing type services, and then you've got PTOT and speech therapy, physical therapy, occupational therapy, speech therapy, and we also provide social worker services. So it's typically short term after a hospital stay or procedure. Or rehab stay. The individual is discharged back home with home health services set up per doctor's orders. And that typically lasts a couple of weeks or a couple of months. Sometimes it goes longer than that, but it's based on physician's orders and their instructions and the provider, the health insurance provider's approval to pay. So that's been most of the home health services that we provide are in those areas. The difference between skilled and non-skilled companion care, we've got a caregiver in the house providing basic companionship or personal care type assistance, and it converts to a skilled level of care, CNA level of care, typically when transfer and ambulation assistance becomes more technical in nature and requires licensing in that respect per regulations. CNAs can also help out with basic like checking vitals and some basic medical oversight that's supervised by the nurse. But that's the main difference, is level of assistance required with transfer and ambulation.
So Damien, can you talk a little bit more about that? And thanks, David, about the, you mentioned earlier training people to be a CNA. What's involved in doing that?
Yeah, good question. So we would pay for 2 people to become a CNA, which basically, I took my CNA class like maybe 2.5, 3 weeks. I think it should be between that and about 6 weeks. The joke, you could take it per semester, but you're spending a week learning how to boil water, right? Like it's a lot. It should be pretty condensed. Just we're busy, and but if you don't have the time, that might be the way to do it. And then the people, we would pay for them to go through the school, and then they would be responsible for taking the test, paying for the test themselves. And we're not having people sign an agreement that they're coming with us. I mean, most people will go with us after we pay for this, but there's no legal standing agreement that they're going to come. But we work with about 6 or 7 schools throughout the metro area, down in Colorado Springs up into Larimer, and then mostly in Denver. We used to do it in person here, and then it became too much. So, but if I could, one of the things that's interesting, and I don't know the makeup of the group. I mean, but one of the things with Class A and Class B, there's an interesting program called IHSS, In-Home Support Services, which is, this is a Medicaid program, and it's only under a couple Medicaid waivers, elderly, blind, disabled, and then there's the kids one, which I won't get into, but another one that's a spinal cord injury waiver, where you can get IHSS, which technically it's considered Class B, but it's IHSS is it's almost more skilled. The Nurse Practice Act is waived. People don't have to go through the CNA school, and they would be competency tested yearly to make sure they know what they're doing. So we're really seeing a lot. Now we're seeing a lot more agencies going to that. We've been doing this for about 18 years, since its inception in 2003 in Colorado. But IHSS is a phenomenal program where people, and a lot of smaller non-skilled Class B agencies are also getting into this because they're discovering it's sort of a way to get into skilled care. Rural areas are trickier because you need backup as per state for some of these programs. IHSS needs 24-hour backup. So rural kind of get the, it's a little trickier. But the CNA, the license itself is in Colorado. You go through DORA, Department of Regulatory Agency. So that's a statewide thing. We don't get reimbursed for sending people to the school. That's the sort of the cost that we have, knowing that. That's why IHSS also makes sense. It saves us a little bit of money because they don't have to become a CNA.
I see.
And then the nice thing about IHSS too is if you have this family member that are doing this. Again, this is a Medicaid program. Under the scope of practice as a CNA, I can only do up to my scope of practice. So I can, if let's say I had a dad who had Parkinson's and he qualified for this program. As a CNA, I couldn't give him medicine. That wouldn't be part of my time, right? My time sheet or my care plan. I would do that as his son, right? Under IHSS, because the Nurse Practice Act is waived, that would be part of my care plan. So it goes above and beyond the scope of practice of a CNA. It's been around for a decade and a half. I mean, it's been around for a while. I think people are just sort of seeing the value of it now, but it's a really nice hybrid program. If a sandwich generation is taking care of an elder, that they know how to do the work. They know what their parents or their kids, they know what works. And having to go through that class, which is just like, it's just extra. I don't have the time to go through a 3-week class because I'm caring for my kid and I'm living a life. So the IHSS really, that the nurse would come in and say, oh, you know exactly what you're doing. And maybe you don't know how to do hospital sheets, but that's okay. And under Medicaid, it's only under 3 waivers: the Children's Home and Community-Based Service waiver, the Elderly Blind Disabled waiver, and then the SCI Spinal Cord Injury waiver.
I first heard this term waiver, a couple of years ago, and I didn't know what it meant. So could you talk a little bit about what is the waiver program in general? I mean, I know there are different waiver programs, but what is that?
Right. Well, each waiver in Colorado, we have maybe 9 or 10 waivers. So for the sake, a Medicaid waiver waives so if I'm on this waiver, it waives, it'll give me extra programs. Like there's state plan Medicaid if you have no money, right? This is all again through this single entry point, which in Denver would be the Rocky Mountain Human Services. You would go through, talk to a case manager. This is all Medicaid, and I apologize with the Medicaid stuff. So we think of the waivers that you would qualify for these programs. So for the sake of this, it would probably be more elderly, blind, disabled. There used to be one persons living with AIDS. There's a lot of ones for people with intellectual developmental disabilities, but for the sake of this, it's elderly, blind, disabled. So it would waive some of the income and let you qualify for this. Which tricky is some people that don't meet even the minimum criteria, so they would just be on state plan Medicaid, which would still be an insurance provider, but it would be less than. So waivers, like most people would qualify for this, so it would just be talking to your single entry point and making sure. It gets a little trickier. Bob or David, how would you better describe a waiver?
I think you described it perfectly, Damien. Yeah. They're basically Medicaid programs. They're called waivers, but different Medicaid programs based on the needs and licensing requirements for the different levels of care. So that's the best way I can describe it.
Yeah. You'd meet the level of you'd meet the level of care, you'd meet financial stuff, but it would, yeah. And again, for the sake of this, it would be mostly the elderly, blind, disabled.
Okay.
Right. There's the Home and Community-Based Services waiver, HCBS.
Right.
And that's pure companion care. And then you got the IHSS, the ones that you do. Those are the two big ones.
And so, but at the end of the day, though, you do have to qualify for Medicaid in some fashion in order.
Yes, sir.
Yeah.
You'd have to meet you'd have to meet eligibility. That's where it gets like the nuances. This is where like a case manager, someone from the single entry point would be really the helpful person. So if I know Sean, I think I heard you were in Colorado Springs, so TRE would be your Medicaid place. If you're in Lakewood, it would be Jeffco Human Services. If you're up in Boulder, it would be ACMI, Adult Care Management Inc. Denver RMHS. There's like 5 of them within the Denver metro area, but they're going to be your case managers, and they'll be on in the nuances with that. But you still, yeah, Bob. I mean, at the end of the day, you have to meet the criteria to get on.
Yeah.
Okay. All right. Thank you for that. So, David, you mentioned this very briefly in your introduction, but let's talk for a minute about Medicare. So what does Medicare cover when it comes to in-home care, or maybe a better question is, what don't they cover? I mean, I don't know which is the right question, but anyway. So David, if you could each talk about that a little bit, please.
Sure. So currently Medicare Advantage plans do not cover companion care, so the non-skilled companion or personal care. And so that's all paid out of pocket currently. Some Medicare Advantage plans have rolled out companion care reimbursements in other states, but not here in Colorado yet. That hopefully will come next year. But yeah, currently Medicare and health insurance plans do not pay for companion and personal care, caregiver type support right now.
Medicare does cover some of the Class A.
Oh, it covers all of it. All of the nursing and therapies that are provided upon discharge from a hospital or rehab stay for a limited period of time. It's not permanent. So typically those episodes last from a couple of weeks to a couple of months, and they can be extended per doctor's orders if necessary. But the patient needs to be shown improvement in progress, responding to the treatments positively. If not, if they start to regress, then they'll be discharged and may need to go back to the hospital or rehab or skilled nursing. Yeah.
Okay. So Rick, I'm going to ask you this question from your experience, and David, you can certainly put it here as well. What is I hate to use the word recidivism, but I mean it's kind of like what is the rate of people who are discharged from a hospital or SNF, go and come home, they're covered for the skilled for whatever 2 to 8 weeks, whatever that is, and then end up going back to a nursing facility?
I might revert this to you because a lot of times it is kind of more on the medical side or PTOT, Bob, and then I can jump in.
Okay.
Sure. It doesn't happen that often, but it happens from time to time. The individuals need to, of course, participate in their treatments at home, even in between visits by the clinicians, especially the therapy side. And family is often trained to help guide the patients through those exercises, and sometimes definitely any daily wound care or IV needs. Typically, family is trained to do that, but without active involvement, engagement from the patient, ongoing, and from family members that are living with the individual. Occasionally they will regress and have to go back to the hospital or decline, go on hospice. So it is important to have that moral support from family and loved ones in the home as the individual recovers, in order to ensure that they recover as quickly as possible back to baseline and get back to a normal life.
So often, Bob, with that, a company like David, they're coming home from the hospital. So we're looking at that readmissions of 30 days. is really important. First off, for the success of the care. So often David's team, for instance, I think we've worked with you, David, where the PT and OT is coming in, a nurse visit, and a family, it takes a village. They're doing their part. They might bring in non-medical personal care also as a 24 hours a day. We're all trying to achieve the success so that client or senior can stay home as long as they can. But we focus on that. So when you ask how many, I know the Class A's are too, and I see the percentages somewhere between 3 and 4 and 5%. Maybe it's more, but we want to have these folks stay home and be successful. So we at Home Helpers, our partners are often. I refer a lot to David and some of the other medical teams, because when someone comes home, that's critical, that first 2 to 3, 4 weeks.
Mm-hmm. So one thought that crosses my mind when we're talking about this moral support and family care and so forth is that a lot of people don't have any family, and that's becoming, as people choose not to have children, which is happening more and more all the time, then that's going to be exacerbated as time goes on, where there is no family. Do you see that as well?
We do. Often it's the social worker or the discharge planner at a hospital will get the call. And, this is where I told you, I've mentioned care management. I don't do case management. I don't have a social worker, but I have a QA department. And our 2 ladies that run that, often, Bob, what you just said comes up. Family lives on the other side of the country, or they have no one here. I'm one of those folks. I'm single, no kids. And so we, again, reach out to partners. There are guardians, people that do guardianships out there, human network systems. That's a group we work with. Often they're working with a lot of single folks. And we try to work with the case managers, but at David's level, and we'll refer to GoldLeaf or another medical company because they've got a social worker or case manager that's going to meet with this family. It is going to be something as the baby boomers, as we're seeing less people have families, it's going to be an issue in the next 40 years. I think right now we're at like 55 million seniors, 65 and older. And in 2030, we're going to be at 71 million seniors. And all of us as partners here, we're all going to be affected, and we need to work as that village to secure safe care for every person.
I think the elephant or whatever in the room right now too is if people don't have that natural support, in the best of times, I'm sure David and Rick would agree, finding staff is, and this is the best of times, it's tricky, right? It's not for everyone. It's not most highly paid, and it's hard work. COVID has been you can't say anything about COVID that hasn't been said a million times. So I think if people don't have that natural, it becomes one extra thing. And if your family is away, or if you don't have family, I would venture to say, as an agency, we still do traditional home health where we send in staff. We haven't taken a new client in months, if not the last year and a half. So it's been tricky because you have to be able to staff that, and you have to be able to staff it well. And we we're at a size as an agency where we're not starving for clients, and if we're just setting ourselves up for failure, it doesn't make a lot of sense. So I think this is a big issue. I don't know, the remedy. I don't know if any, I don't know what the remedy is if you don't have that natural thing. And I feel like we've been talking about the CNA shortage for the last 15 years, knowing that we need them and we're not getting people that are doing these jobs. I think as agencies, we have to do a better job paying. But Denver's an expensive city, and even if you paid $18 an hour, it's still $18 an hour in Denver, right? Where housing is expensive. So it's a really good question, Bob. I don't know if people don't have those natural supports, I mean, I think potentially there's neighbors. I mean, there's other people that can fill the gap, and I think some people don't know that they can get paid for it. I think they assume it's a professional's job, but there might be this natural support that they don't even know exists that could potentially do that. We've been paying our CNAs roughly 17 an hour. I think it was 16 and some change, and then by experience it would go up. But yeah, there's agencies that are paying less than 10. I mean, like you hear crazy stories, and like it's no wonder that you can't keep staff. But 15, I think in Denver, that's now a thing.
So with these family caregivers that are getting paid, or neighbors, whichever the case may be, is that will be the $15 an hour then minimum?
I can only speak for Pasco. Pasco, we start at 16 and something. It's 16 and like 30, 16, 30 an hour. And then, I think back to what Rick was saying this earlier about 24-hour care, we're probably similar to David, that this is all intermittent care for us. We're following a care plan, which typically is like 3 visits a day. So maybe in the morning, it's 2 hours. In the afternoon, it's an hour and a half. And then at the end of the day, it's 2 hours. So it'd be 5.5 hours a day. And then we would pay time and a half for overtime. So yeah, I think that no one's getting, this program is really a stopgap. Not a stop. I mean, it's a very good program for families that have been able to utilize this. I think about families with kids, especially with some profound needs, but I think even with adults, it's been able to help keep people engaged in the community. And like a lot of people have to lose jobs. They don't have that thing. So it's been helpful.
Okay, well, thank you. I'm going to move on to kind of a little bit different area right now, and that's licensing. So the subject of licensing has kind of been, touched on. You mentioned DORA. So for skilled care, what licensing agency do you have to go through to become licensed in Colorado?
You have 2 choices. You can go directly to CMS, Medicare, Medicaid office, or an accreditation body like JACO, CHAP, or ACHC. We're accredited by ACHC. So we went through them. Typically takes about six months. And you have to have a certain number of patients on caseload. You provide pro bono for a certain period of time, and they'll come in and conduct a survey and some site visits. And if everything goes well, then you get certified, receive your certification licensing for Medicare and Medicaid.
So do you have to then have kind of regular checkups like annually or something, or how does that work?
Well, the state of Colorado will request that you renew their license every year, just like they do for the non-medical Class B licenses. And ACHC will come in and do a reaccreditation survey every 3 years. So that's the accreditation for Medicare and Medicaid. So it's typically every 3 years.
Is the Colorado Department of Health and Environment, are they involved in this licensing in any way?
Oh, sure. Well, they're the localized NERs for CMS here in Colorado. So they're affiliated with CMS. So they're the ones that the surveyors that come from CMS, if there is a survey required, will be from the Colorado Department of Health.
And that's how you're licensed too, Rick. Is that correct?
Yeah, the Colorado Department of Health, right? And that's how all the Class Bs are. First off, David, I can remember when you went from Class B to Class A, and I was very proud of you because that is a process. And David comes with such a heart. He does it the right way, your team. But yeah, we're under the Colorado Department of Health. We get certified on an annual basis, Bob, and then audits 2 to 3 years. I've been privileged to have about 5 of those since we opened. Damien, I see you smiling, but it's a great process. Before, I think it was 2010, before that, there wasn't licensure for the non-medical personal care agencies in Colorado. And they do a great job making sure that we all statewide are doing it the right way, following all the everything that we need to be following as an agency, training, documentation, that you're bringing in caregivers that pass background checks, and that you've got ethical, just wonderful people working for your company. So I have found the experience with Colorado Department of Health to be a good one.
Okay. Okay. And Damien, you're subject to the same licensing? Yeah. Okay. Okay. All right. Thank you. So when people are looking for an in-home care agency of whether it be Medicaid or Medicare, so would you guys, suggest that they look to the CDPHE website to make sure your license is current?
I think that I just had this thing in front of me that was like evaluating home health agents. I can't see it. I swear that's what it is. And I think there is a certain amount of onus on people to do vetting. There's a lot of agencies that are alphabetical, and because they come first doesn't mean they're the best. 6A medical might not be the best medical. They just have a lot of A's in their name. I think probably it probably wouldn't hurt through CDPHE if they have their license, right? If that's in current standing. But I also think they need to ask, how long has the agency been in business? What's the average tenure of their staff? What services do they provide? Insurance do they accept? All these kind of things. Do they have a backup plan? Is there we're proud. We've had the thing for a number of years where we have a runner. They're on the clock, but they don't have a schedule. So in case something bad, if something interesting happens, they can be deployed immediately or whatever, immediately in Denver, 45 minutes. So I think there's a lot of questions. I know AARP has a lot of good resources for questions people should ask agencies. What do they pay? Is there, what are their staff like? So I think there's a lot of questions besides, my sense is that if you didn't have a license, you couldn't really take anyone on. And I don't know if you want to mess with that. I don't know that part, but I think there's a lot people need to vet on their own. And a lot of questions to ask providers.
Well, and these are good things for us to know too. So as part of our vetting process for inviting providers to be, part of AgeWise, do you have to turn potential clients away? And when you do, how does that work?
We have a lot of problems because I think we do a good job with our search engine optimization. So people see paid family caregiver and immediately their interest is piqued. We're a Medicaid agency, so I think people don't always know the difference between Medicaid and Medicare. So we, if we say we're Medicaid, and people are like, oh, I get it, my dad's on Medicare, and we're like, yeah, but we're Medicaid, and they go, yeah, we get it, my dad's on Medicare, it's good, and they're different programs, right, entirely. So, so that's probably the biggest one that we're just not a good fit. We tell people sometimes we give them names of other agencies that potentially. Right now, as far as staffing as an agency, that's where it gets like, we're telling people to keep looking. We have a few agencies, but I don't know anyone who's really taking on new people right now in this sense. And I think this is my little thing with the Medicare, Medicaid. Medicare short, 60-day acute, coming out after having hip surgery. Medicaid long-term. Think about someone who has a stroke or someone who has a spinal cord injury. It's CP. That would be a good way to think about it. But that's kind of, I think the intake team, they have a list of numbers that they can give, and hopefully that we know those agencies that we're sending them to. We also vet like agencies. So I sent people to Rick, I've sent people to David if it doesn't work here. Not just cast-offs, but people that we can't serve as well.
Okay, thank you. Rick?
Absolutely. Same that Damien said, we refer out a lot of times. If it's a client we can't work with, it may be because it's medical or they need CNA coverage, or it might be, I get a lot of Medicaid calls. So Damien, I love what you just said. We never just say we don't do that. We talk with our family, vet what they need. And if we can't do it, we're going to work with our partners, with AgeWise, with, again, I refer a lot to Pasco and GoldLeaf myself. And so the call we usually can't do is that. Another thing is happening now, the non-medical personal care Class B companies, there's some great folks all throughout Colorado. What I'm seeing now is there is a staffing shortage. So if I can't staff it, and David, I think you and I just talked last week, I'm going to call one of our partners and see if they can help. It may be down to that they need a male attendant with their dad or mom. We don't have it, or it may just be that we can't cover that shift. So we don't ever want to hang up the phone. We want to, get them to 2 or 3 of our friends or partners so that mom or dad can get the help they need.
Okay, thanks, Rick. David, do you have anything you want to add?
I think they summarized it perfectly. The important thing is to realize that there are a lot of resources out there. Most of the time when people call, they're at their end. It's a very stressful, taxing experience caring for loved ones, and most people don't plan ahead far enough for these types of situations. So most people are pretty desperate when they call, and as much guidance and support and direction and information you can give when you're doing that intake call, and everybody's better off in the long run. So lots of resources out there. You just need to know where to go and who to call.
My last question, and then I think we have 1 or 2 questions yet in the chat. But my last question is to you, what's the most gratifying to you in the work that you're doing?
I think my team and the folks I hang with here in Colorado that are giving wonderful care out there, it's working with the families. And often, I've always said there's not an 800 number that we can just call and get all the answers. That's why AgeWise Colorado is going to be such a wonderful component of what we're doing here in Colorado. But I love helping the families, working through, taking some of the stress away, being able to let them know that there's programs like Pasco, or that this is what medical companies can offer versus non-medical, and educating them. The other thing I really love about what I do and what we do is being that employer. I heard Damien talk about the benefits that he gives to the families, having health insurance, and that brings me a lot of joy. We have about 112 employees, nothing like the size of Pasco or probably David's team, but those relationships with the employees. What's going to help us a little bit, it's going to be agency by agency, is if you're a great agency or company that's taking care of your people, hopefully retention, they stay with you. And so that's what gives me joy, Bob.
Same as what Rick said. It's a very rewarding type of work, helping people age in place and helping people recover after a procedure or an accident, a hospital or rehab stay, and hearing kudos and accolades from patients and clients and family members on a weekly basis really warms the heart. We do random impromptu surveys to all of our patients and clients, and we hear nothing but good things about our clinicians and caregivers in the field. So kudos to them, and it's really a worthwhile business to be in, and I enjoy it very much.
Okay, thanks, David. And Damien.
I think to echo those things, and also this is confusing. This is a really confusing time, and I know, I'm really happy to have AgeWise come in, because I think I'm going through this with my mom now, and it's just very confusing, and it's probably intentionally confusing. So I think that help people with resources. And like, I don't own any of these resources. I think they're for the public good. I think just helping people navigate, it's because it's tricky, and I think people are vulnerable. And there's, like with anything, there's good actors and bad actors, and sometimes the bad actors, you hear about them more, but they prey on that vulnerability. So I think just helping guide people, and maybe we're not the best agency, but work for them at the time, and that's okay, because there's other good agencies. So I think just helping with any of those guiding and just in that space.
Okay, thank you. And as we've learned today and in other venues as well, Medicare and Medicaid are quite different, and many people don't understand the difference.
I mean, you have legislators that don't understand the difference. I mean, so it's not like you have people at the Capitol who don't really know. So
that's very true. Yeah, you're right.
Yeah.
So we had a couple of questions here about rural areas, and I would just ask for any of the three of you to comment on that. I mean, you can see the chat too. So what would you have to say about rural areas where, you just don't have the I guess the critical mass that we have here in the Denver metro area?
there's definitely an urban bias. I mean, I think that's, I think to see those things, and we've known it, right? If you have a disability, or if you live in rural parts of Weld County or Routt County, like you're really, you're up against it. I think there's places, most counties have independent living centers, ILCs, that can help with some of those, people navigate. They're good resources to have. I think just vetting, a lot of places there's probably home care in most smaller places. I would just, people need to do that. And it's trickier. It's always been tricky, the rural divide. I would start with ILCs though. Most county seats should have them. And they can help guide.
Okay.
Yeah, Sue's Lee, what I'll do if we get families, I don't do Medicaid and we're not medical, but what we will do, and what I'll do is I'll get on, thank God for Google, I'll get on, pull the county up, and often I'm referring to a community, or if there's a home care agency that does A and B, I will get them that information. We get those calls every week, and even though we're in the urban, right outside of urban, even areas like up in the mountains, it's hard to get care often up to somebody. It might be in Pine. So again, I kind of go to the village group here, and I do know some agencies that go further out from where we are, including Weld County, Jackson. So it's all working together to get that information out. Maybe I need to open up a satellite office somewhere out in a rural area too. That's something I think some of the home care agencies, I've got a couple of friends that have talked about doing that, just to get these folks. Often it's the farmer or somebody that maybe lives out. I get a lot of calls for, I'm going to say around Kiowa. You get a lot of calls for people who live way out, it's not way out, but it's far enough out that I know it's hard to get a caregiver out there.
There's a place called Colorado Cross Disability Coalition. They are statewide. Again, we're talking more about people, elders, and not people with disabilities, but they can be a good resource too. That would be I would utilize. I mean, it's really tricky, and then driving, and then drive time. I mean, I'm looking at Jackson, Colorado Cross Disability Coalition, so it's CCDC. Carol?
They're located here in Denver.
They're in Denver.
Mm-hmm.
So this made me think about something. So is there any possibility? I mean, do you see any possible way to maybe form some kind of a coalition of? This is really, I guess, more for Rick, and well, it's for all three of you actually. Some kind of a coalition where one provider wouldn't be taking on this task of trying to serve these very rural areas. That you have kind of like 3 or 4 different agencies get together and say, okay, we're going to set up an office in Jackson County, for example. And I mean, I don't have any idea how that would work, but it's just something that, you kind of mentioned it in a way, Rick, but yeah, could you talk a little bit more?
Bob, that's a great idea. And with us, we've all become pretty proficient with Zoom meetings now. So it might be a wonderful thing. I know you and I were both involved with a company, agency, or excuse me, a little help. I don't know how to describe that, but I know they've taken that program to other chapters around Metro Denver. So that might be a partner to take a program like that into the rural areas of Colorado, Bob. And like you said, form a coalition where we met monthly with Zoom meeting to help Lee, help you and Susan, folks that deal with rural Colorado, because there are a lot of folks in their 60s, 70s, 80s, and older that live out in these communities.
Right. And I think too, I saw another one from Lee about Medicaid. If they're close to being on Medicaid, and if they're, I think there's different programs for people that can help get people on Medicaid. There's a place called Beneficent down in Colorado Springs that's been helpful a lot of people. Helping Hands. And you can email me and I can get you guys numbers for some of these people that, if they're kind of in that donut hole where they're close to getting onto Medicaid.
Right.
Because IHSS, you're saying should be on for non-Medicaid. Really, like if you are private pay, then you can pay privately, right? Or insurance. And a lot of this insurance, as David said, it's not going to cover this because it's custodial in nature. So a lot of insurance won't cover this. So it's really going to be private pay, and you might not have an agency. A lot of this stuff per regs, you have to have 24-hour backup. So really, one of the things that we were doing, we went down to Southwest Colorado and we sent a thing for all the CNAs because that's on Doris. You can find their names and then just send them cards. Are you interested in working for us? Or same with nurses. If you had a nurse up there, like you could potentially make an agency using this family caregiver model or this thing. I think it's tricky. There's a lot of stuff, but there's not a lot of things happening in those areas. Like, I don't know if Walden has any agencies.
Right.
And it's all regs. Like IHSS, I'd love to be able to serve Steamboat Springs. I'd be up there every weekend, but we don't have nurses up there, and it's tricky to get up there. So
I guess a point here could be that maybe there's a legislative solution that could be developed, to encourage this kind of thing to occur in these rural areas. You mentioned earlier, that many legislators don't know the difference between Medicare and Medicaid, and that's very true. They may not even be aware of the shortage of providers in their particular area, or it hasn't been elevated to a level where they actually try to do something about it. I guess that's probably a better way to say it. With HCPF, HCPF, kind of in the middle of some of this, but not all of it. I know that they're working on some programs right now to help with a variety of things, but I don't remember, I've attended some of those meetings. I don't remember seeing anything specifically about rural Colorado. That's not.
Well, one thing that's come out of COVID that we've noticed, if there's a silver lining, is the expansion of telehealth, which will certainly help in rural areas as far as getting some of these services done if you have a Wi-Fi connection. So telehealth is like, that could be potentially be something. It's certainly not going to be the nuts and bolts of everyday helping with ADLs, but some of those other needs it could potentially help with. So
yeah, that's an excellent point. Yeah. And that is where it's going. And then like David said, with robotics, we still have a few years to see that maybe develop, but telehealth is definitely something I would look at, Lee, Suze. Care.com, you might have to get in and look there, and you'll see non-medical personal care folks on there, nurses, CNAs. So that's another venue. I know I've referred that out to some of the mountain communities, and they have been able to find a neighbor or somebody that's looking to work. and then that taps that into IHSS. I love hearing about that program.
And is there a home care agency association? That's a new question. So do you, Rick, David, Damien, do you have an association of agencies here in Colorado?
Well, you've got the Home Care Association of Colorado, and they're very active. And I'm actually thinking about getting back involved with them. We're going back when they were, oh my gosh, David, NADP. We're going back a lot of years. But the Home Care Association of Colorado.
Okay. So that's a voluntary membership organization.
Yes, sir.
Well, I think with anything there's a certain number where it becomes profitable for an agency, and I don't know how many clients that is. Yeah, it gets tricky because I would imagine in some of those, like Rowe County, I think that's Steamboat, right? Like Steamboat probably has 3 agencies. I don't know if Walden has any. I mean, but there is certainly like a business case to be made to say like, oh, people want to live at home and you don't want to move, right? It stinks like we're, especially in the Medicaid space, is Colorado has a pretty good Medicaid program. Mm-hmm. We did expansion and we did a lot of this other stuff, but we had a good program. But people from other states, I've helped a couple people move from Tennessee because they just don't have the resources in Tennessee for Medicaid. So it stinks that people have to leave where they live to come to get better services. But now, if they have money, if they're private paid, that's a different thing. I think that could be, for a while at least, unless they have unlimited money. But
okay,
you just got a county nurse. Yeah, you guys, are you in Walden, Suze?
Yes, I am from Walden. I am in Walden. And the problem is, gentlemen, is that we have 1,200 people in the valley, and that's 1,200 square miles. So, when you talk rural, we are rural. We're not only rural, we're what they call frontier because we're missing at least one major help. We don't have dentists up here. We have a part-time doctor. We have no hospital. We have a healthcare clinic that's excellent. Our best healthcare is our EMTs.
Yeah.
So, and I have one little girl up here that's just busting her butt, but she needs help.
It certainly sounds like there's some things that could be done through the legislature that could be helpful. And having worked with the legislature for the last few years, I'm also very clear that nothing happens very fast. But but you got you have to start. So I would suggest to you folks who are in the rural areas that maybe you attend some of the Colorado Center for Aging Monday morning meetings. I think the next one is next week, and maybe bring this up there. Yeah, the place to start.
And Suze, this village, us all getting to know each other. I love this meeting. I'm going to get your email, and maybe as agency owners, we can put a blast out to our networks and see if there's any contact we have that can help you down in Walden in that area. Walden's south of Pueblo. Is that where Walden is?
No, Walden is below Laramie.
Okay. Oh, yeah. So you're okay. Okay. Well, I'm going to get your email from Bob, and we'll mastermind some ideas here.
Thank you so much.
You're welcome.
I want to thank our panelists. I mean, this has been really great. I've certainly learned a lot, and we appreciate you folks being on and the questions that you've asked, and I hope it's been very helpful to you as well. Barbara, do you have anything you want to add? Sorry to put you on the spot here.
No, that's okay. This has been extremely informative. So I thank you, gentlemen, because we keep building our knowledge, and great to meet everyone that's been attending.
Okay. All right, folks. Well, if there's nothing else, thanks again, and I'm going to sign off. So
thank you, everyone.
All right. That's appreciated.
Thank you. Good luck, everybody. Have a great day.
All right, bye-bye.